Hello everyone, welcome back to my channel. This is Dr. Neha. So NEETPG exams are coming up, so I thought before that I'll start a series in which I'm going to tell you 3 must-know PYQs for NEETPG based on the previous year questions which have come. This will help you revise the topic as well as those MCQs. I'll try to put out these videos every day or at least every alternate day for your revision. So what is the first question today? What is the numerator in proportional mortality rate? Is it the number of death due to a particular cause? Is it the number of death during that year? Number of death in 1 month? So what is proportional mortality rate? Simple है proportion. Okay, that means कि कुछ बहुत सारे में से थोड़ा सा. Alright, that is what is proportion. So what is it here? Proportion mortality rate simply means whatever is the number of deaths due to a particular cause. Okay, due to a particular cause. Let's say in this the particular cause we can say is tuberculosis. Okay, out of the total number of deaths, okay, out of the total number of deaths which has happened during that year in a particular age group, also we can say multiplied by 100. So this is the answer to the question. Numerator is number of deaths due to a particular cause. If it was the number of deaths, let's say if I asked you number of deaths due to TB out of the total cases due to TB, what will this be? This over here multiplier again is 100. This is nothing but CFR, case fatality rate. So number of deaths due to a particular cause, it measures, PMR measures the proportion of total deaths due to specific cause or proportion of deaths in a particular age group. So number of deaths due to a particular cause per 100 total deaths. It is one of the simplest measure for estimating the burden of disease in a community. This can also come as an MCQ. The best measure of burden and effectiveness of intervention is DALI, but the simplest measure is this one, proportional mortality indicator. It's a useful health status indicator, indicates magnitude of preventable mortality. Okay. All right. Now, next question. What is population attributable risk? One of the most important questions. So, population attributable risk is actually a measure of strength of association in a cohort study. All right. So, suppose we are trying to study the association between, let's say, smoking and lung cancer. Alright, so over this side, always on the column side, you have the disease. So lung cancer, yes, no. And on the row side, you have the exposure. Smoking, yes, no. Now this one is A, this one is B, this one is C, this one is D. So there are 3 measures of strength of association in a cohort study. The first one is relative risk, or you can also call it as risk ratio. वो क्या होता है? That is incidence among exposed, all right, divided by incidence among non-exposed. The other one is attributable risk. What is attributable risk? Incidence among exposed minus incidence among non-exposed divided by incidence among exposed multiplied by 100. And the third one, which the question has asked to all of us, is population attributable risk, which is incidence among total population minus incidence among non-exposed divided by incidence among total population multiplied by 100 again. So here we have to see what is incidence among exposed. So if I ask you what is incidence among exposed, so who all are exposed? The total जो exposed है to smoking is A plus B. Who are non-exposed? C plus D. So what is incidence among exposed? A plus B is exposed. इसमें से incidence कितना है? कितनों में lung cancer हुआ? A में हुआ. Incidence among non-exposed, how many are non-exposed? C plus D are non-exposed and incidence has happened in C. So you can put this in the numerator and denominators. But for population attributable risk, the most important thing is what is incidence among total population? So that is What is the total population? Total population is A plus B plus C plus D. उसमें से incidence total कितनों में lung cancer and how many? A plus C. So this is what I just wanted to clarify for all of you, that what is going to be incidence among total population and this. So if you are asked population attributable risk, what will be the answer? Let's see the first one. Incidence in exposed and incidence in non-exposed compared with incidence in exposed. ये कुछ नहीं है. Incidence in total population and incidence in exposed compared with incidence in population, no. Incidence in population and incidence in non-exposed compared with incidence in population. This becomes your correct answer, because D is also incidence in population and incidence in exposed compared with non-exposed, no. So C is our correct answer. What is population attributable risk? Defined as difference between incidence in population and non-exposed compared to incidence in population. Suppose we were studying smoking and lung cancer, population attributable risk comes out to be 70%. So what is the interpretation of this? Next time you could get what is the interpretation. So it simply means that if smoking, okay, is eliminated, okay, or modified as a risk factor, ठीक है, if smoking is eliminated as a risk factor, then there will be what? Then there will be 70% reduction in, annual incidence of lung cancer cases. So this इंसिडेंस ऑफ लंग कैंसर केसेस, अगर हम स्मोकिंग को रिमूव करते हैं या एलिमिनेट करते हैं, 70% रिडक्शन इन एनुअल इंसिडेंस ऑफ लंग कैंसर केसेस. सो PAR इज बेस्ट फॉर यूज बाय पॉलिसी मेकर्स. लाइक attributable risk is how much? Like 75% of lung cancer occurs due to smoking. So that is of importance to epidemiologists or community physicians, but PAR is for policy makers. Let's come to the last question of the day. Bladder cancer can occur in those who are working in chimney for 25 years. What is the best study for this relationship? It is meta-analysis, cross-sectional, RCT or cohort. Basically, here the question is, which study design, best study design to establish causality? This is what they are asking. Which study design is the best to establish causality? So what is this going to be? Of course, if we look at the evidence-based pyramid, okay, I'll quickly draw the evidence-based pyramid for you. We all know evidence-based pyramid is the one by which provides us evidence to establish causality. Our focus of all epidemiological study designs is to establish causality. Okay, so studies are arranged in a hierarchy. Lowermost, सबसे नीचे क्या होता है? Descriptive study designs, case report. Okay, उसके बाद क्या होता है? Case series. After that, what comes? After that comes, this is asked in a lot of entrances, analytical, जिसमें ecological. Then in the order is cross-sectional study design. After this cross-sectional study design, it is case control study design. Then it is cohort. Cohort maybe it is prospective. All right. Then it is your cohort retrospective. All right. After retrospective cohort, here you have RCT. RCT के बाद systematic review and meta-analysis. So the best study design to establish causality is meta-analysis. Now look at the answer over here. As a single study, of course, double-blind RCT is the best. The efficacy of new interventions are most readily accepted if results are from RCT. However, overall meta-analysis is better since it combines the data from multiple RCTs and also from other types. Like maximum evidence आपको meta-analysis से मिलेगा, because it's going to combine the results of all the individual RCTs which are demonstrated by a forest plot or a blobogram in an meta-analysis. We'll be looking at this in subsequent PYQs. Thank you so much for watching. Hope you liked it. Any comment, put in the comment section below. Thank you so much.